All right, Abhishek Choudhury is next up. He is Assistant Professor of Industrial and Systems Engineering at West Virginia University.
Hello, everyone. Thank you for inviting me here. So today I'll talk about trust and factors that affects acceptance of AI in day-to-day clinical work. So throughout this day, we have established the fact that AI can do it, and it is essential. So I'll not waste time on that. So this slide shows how AI can help in precision oncology or healthcare in general otherwise. And there are several evidence published that shows how AI can help in streamlining the workflow, how it can expedite diagnosis, how it can improve care quality. And also recently, there have been almost 520 FDA-approved algorithms, of which 396 is radiology. But then why can't we see any doctor using it if we just walk down across the street in a clinic? A cancer doctor is not using an AI. Why? That's the problem. So there's many factors that's leading to this, one of which is trust. So I define trust as a moment when a doctor is willing to change his or her own decision based on AI's recommendation. And I emphasize on this factor of change because we can get confused between trust and bias, and I'll talk about that later. And this problem of trust is well acknowledged by many human factors engineers. And there have been many research done on emphasizing the fact that people should design their systems, their AI, their workflow, everything to optimize trust, not to maximize it, because maximized trust is blind trust. If we blindly trust AI, and then in 10 years from now, if that particular algorithm, which is continuously developing based on the data, starts giving biased output, then we will create a mass destruction, because the feedback that we get from patient health is not immediate, unlike any automated or industrial setup. So people are right now pitching for optimized trust, and many research are being done to improve AI transparency, ensuring its robustness and fairness in AI. So the problem here is, when do we know that someone who is actually using AI in a research setting is actually trusting it? Is that person only saying, oh, my AI works great, when his judgment is matching with that of AI and he's using it? Oh yeah, it's great. But what happens when AI says it's healthy and you think they have cancer? Or AI says they have cancer and you think it's healthy? Then what? So there is no guideline as such for new doctors, new residents. I'm not talking about attending with 30 years, 40 years of experience. How will a new doctor judge? Suppose he is treating a patient, looking at the images and everything, and he thinks the patient is healthy. But then he gets a notification from that software he's using saying, okay, he has cancer. Now what next? So when we look at this trust or willingness to use something, there are two aspects of it. We can divide it as initial trust and then trust evolution. So initial trust is when, if I'm a doctor, I walked into my clinic today and suddenly my manager said, okay, hey, we have this new AI from this X brand, this the biggest Ivy League brand, has this kind of a history. And now I have to decide from that day onwards, do I wanna use this or not? So that initial trust, I have no experience with AI, I don't know how this works, but what I have is a common perception of AI, which is very important to establish in order to ensure that I'll first, on day one, will actually give it a shot. And if by saying this, when I'm saying, what do we know as, excluding the people sitting in this room, because you all are the leaders and expert in the field, as a common man or a new doctor in a low-income country or a county in West Virginia, what is AI to that doctor? AI is to that doctor is a technology that works better than him. It's a technology that can diagnose more patients than he can. And so that is the perception. So you are pitching AI in a way that diminishes the expertise of an individual, and you expect that person to accept this technology and use it, right? So so there is a challenge there. So we first need to ensure that the perception of AI is improved. And then once we start there, and people actually start using it, not in research lab, not in Ivy League research hospitals, in general common hospitals, then we can get to the second phase, which is how that trust evolves. And it is at this phase, the performance of AI, the ethics it follows, how generalizable it is, how it ensures privacy, and all of that comes into play. So suppose I used the AI on day 1, it worked well. Day 2, day 3, for 6 months, it's working fantastic. I used to see 10 patients a month, now I am seeing 30 patients a month. And then after 3 weeks, I got a feedback from a patient that, okay, this decision taken on last Thursday resulted in this patient harm, because then there is a 3-day or a 4-day delay. Now it gets very complicated to trace back where was this error. Was it my decision that was the cause of it? Was it me, or was it that AI software that either influenced my decision, or where was the flaw in that whole system? So it gets very complicated to trace back and then solve it. So at this point, what I'm trying to pitch is this whole problem is not a computer science problem, it's not a doctor medical problem, it's a systems problem. We need to have a very clear, complex, and well laid out workflow. So if a patient with breast cancer is there from day, what's the patient's journey? What are the stakeholders involved from day 1 till survival or till death? And in those processes, where can AI help and how it can help? Once that is established, it gets easier to use this feedback loop and correct in case of any harm in future. So what happens, another thing as far as my work is, I found this problem accountability, a huge hindrance. So there is a hospital, I can't name it. So they are using an AI-based application which helps them identify how many blood packets they need for a given patient. So they use it for blood transfusion purposes. Even though it's proven that AI can and have been doing better than the doctors there, only 46% of the time they even consider looking at the AI screen. They just go, click cancel. Every time the AI pops in, they click cancel and do what they do. When junior doctors who are interested in new technology, they come across this app or this software, they see that the recommendation from the software is maybe 2 packets of blood, and he or she thinks it's 1 packet of blood. They don't know what to do next. Do they go with the AI, or do they go and talk with the attending? Usually they go and talk with the attending and then just follow whatever the attending says. So in this case, what's happening is they have spent so much of money to implement the software in order to reduce excessive blood transfusion. This software is not being used. So the efficiency and whatnot, no one cares about it unless and until you actually use it, right? And then doctors are also scared of, where in a survey I found people are saying that, I don't want to use AI, ultimately it will affect my license. It may create extra workload for the doctor to explain it to the older patients, how he or she is using the AI, what is that AI? So all of this, when we look at it from a larger perspective, it's kind of adding to the clinician's workload instead of making the things easier for them. So this is something we can see only when it's been used in a medium to low resourced, average-sized hospital. Apart from trust, there are many other factors which indirectly affects trust, but it also affects our willingness to use or adapt this technology. Another thing is we must think from the user's perspective. So what's happening as of now in the research field is kind of, we have developed this amazing AI tools, and we are trying to impose it to the doctors without making sure that the doctors realize how it can help them. The only thing, the message that they are getting is this is better than them. That is not the message we want to convey. We want to convey the message that how it can improve their efficiency. If they are efficient at 90%, and now if they are using this AI, they can do better. That message has to be conveyed well through research. Otherwise, as I mentioned earlier, even if we do integrate a fantastic AI in a clinical workflow, people might just skip that part because by law, they will be held accountable for any harm. Then why using this? Why take that risk? If they had to be punished, it's better because of their own fault, not because of a third-party fault, right? So if I had to give 3 recommendations, these are the 3. First, we need to establish a shared or a distributed accountability, where the accountability will depend on what's at risk. Is that AI is doing a final diagnosis, or it's doing pattern recognition and telling the clinician, hey, you can look here. So what's at risk, the intended use? Human factors consideration, as the speaker mentioned, that integrating such thing in an EHR will definitely complicate the work. EHR is already very complex for any nurse or any doctor in a regular hospital. Every time I've talked to any doctor, what's your opinion on EHR? It's never positive. Okay? And it should be a need-based integration, not impose a tool because it has been developed and it's working so great. It has to be a bottom-up approach so that the doctor or the end user realizes how this particular tool is helping me. And once we have this approach, over time, the trust and the integration and the whole culture of healthcare will evolve, and then AI will become a part of clinical workflow. So that's all my speech. Thank you.